Hey, folks. I'm Elena.
I'm Darah.
And this is Where's the Adults? Podcast about being caregivers when you don't feel like you're the one to do the job. You mentioned about things just being like a normal part of aging and people just assuming. Could you speak on the difference of like dementia and Alzheimer's, people thinking that they're interchangeable, and like what is normal sign of aging and what is like, oh, we should probably call the doctor?
That's a great question. So there is a lot of confusion around those terms. Dementia is an umbrella term that really means memory loss plus difficulty functioning in day-to-day life. You have to have both to call anything dementia. So just having a little bit of memory loss, but if it's mild and it doesn't affect somebody's ability to function in their day-to-day life, we call that mild cognitive impairment. Dementia is when we're seeing that memory loss plus functional decline. And then under the umbrella of the word dementia, we have different brain diseases, different types of dementia. So Alzheimer's disease is the most common. The next most common is vascular dementia. So those are people that tend to have vascular disease in other organ systems and circulation problems that affect the brain. And then there's a few less common types of dementia. Parkinson's disease can be associated with dementia. There's something called dementia with Lewy bodies. There's frontotemporal dementia. So there's a couple different less common types. But another really common form of dementia is what we call mixed dementia, where people have features of more than one. And unfortunately, there's no very precise way to diagnose exactly what type of dementia somebody has. We're getting there. There are now some tests out there that can look for specific types of abnormal proteins that make up plaques that form in the brain, especially in Alzheimer's disease. But those tests are still not perfect, so they're not really in widespread use yet. Dementia is really what we call a clinical diagnosis, which means it just takes me talking to a person and their family. We have some different tests we can administer in the office that can help tell us a little bit more about how somebody's brain is functioning. We do things like MRIs and different scans, which can give us also some additional clues. But unfortunately, there's no one single test that definitely gives us the diagnosis and not the specific diagnosis. So we have to just look for patterns. We have to look at symptoms. Sometimes we have to look over time because occasionally somebody can present with symptoms of dementia, but really it's because of another thing. It might be that they're taking a medication that is affecting their thinking. Sometimes people who are very depressed as they get older can have difficulty concentrating and memory loss, and that can start to look like a dementia, but really if we treat their depression, we can make them a bit better. So there's a lot that goes into that evaluation. And just for anybody listening and watching, this is definitely something a primary care doc can and should get the ball rolling with. You don't need a geriatrician or a neurologist to make that diagnosis, but you need somebody who's going to really put some time in and kind of do a thoughtful evaluation and really look at the person from head to toe, make sure the medications are right, make sure there's not another disease process going on in another part of the body that could be affecting the brain. So it does take time. And unfortunately, primary care docs don't always have enough time in their visits. Sometimes the typical primary care doc, in the community might only have 15 minutes for a visit, and it just takes much longer. So sometimes spacing that out over multiple visits, that evaluation can be a strategy. But I tend to see patients that maybe are having trouble getting a diagnosis or maybe a more complicated case. But one thing I'm trying to do in my work is really teach other clinicians on how we can make that diagnosis, how we can try to be efficient with that process, get the patients and families what they need. But it does take a lot of digging sometimes. As far as normal aging goes, I definitely get some people sometimes that come to me worried about their memory, and I really end up, we'll go through some of that testing. We'll say, you actually don't have a memory problem. This is more normal aging. So any of us, as we get older, the brain gets more vulnerable to things like stress, sleep deprivation, illness. So that can lead to different lapses in memory. Where did I put my keys? Oh, I forgot about this appointment. So some of that can be normal, just especially in the face of a big life stressor or lack of sleep or an illness. It's really when it becomes kind of a pattern and it's starting to become noticeable to other people, or it's interfering with day-to-day function, things that used to be easy. Remembering where you're going in the car, functioning at your job, if the memory loss is starting to impact those things, that is concerning.
So for families out there that are like, oh, I have an older adult and maybe they live in a county or a state that it's hard to get access to like a geriatrics team, what advice would you give them?
It's tough. I think creating a community or finding a community of just people who are going through what you're going through as a caregiver and leveraging that to get connected either to a set of providers that might be taking care of the loved one of a friend or another family member. Also, the Department of Aging can be really helpful. And every county has an area agency on aging. So now sometimes, they are also stretched thin and kind of dealing with their own shortages, but they should be able to get people connected with at least some resources. It's a good place to start. The Alzheimer's Association, for people who are caring with somebody living with dementia, that can also be a great resource. They have really great forums on the website. They have a 24-hour call line. So that's a really good resource for somebody that doesn't have immediate access to a geriatrician. But I think just, finding that network, it really shouldn't be this hard. And that's something that I'm working to change, at least here in Southwestern Pennsylvania. One thing that I talk about a lot is that if somebody's diagnosed with cancer, which is of course terrible, it's very easy to access resources for cancer care. We have great cancer care in Pittsburgh. When that diagnosis comes, a person is sort of immediately enveloped in resources, social work, dietitian, support groups, education. When somebody gets diagnosed with dementia, that doesn't happen at all. A lot of times it's, here's your prescription, try this medication that doesn't work very well, and that's it. And it's not because primary care docs don't care or don't have empathy for that situation. It's just there just aren't enough structured resources. There's not enough attention on that issue. So that's something I'm really trying to change by creating some of these programs that can work with families and help get them connected to that community that they need.
Can you share with us what programs you're trying to develop?
Yes, I would love to. So a few years ago, we received an award through the Hillman Foundation to start a program called the Aging Brain Care Program at AHN. And this was an evidence-based program that was already in existence in other places. It was actually started by Indiana University. An expert geriatrician there had created this program years ago, studied it, showed really good outcomes. And what the program is doing kind of those things that we just talked about. So really helping to navigate caregivers through the process of caring for their loved one with dementia. So it's focused on dementia care, and it's really focused on the caregiver because this is a family illness. It affects everybody, as that person loses their autonomy and has trouble functioning in their day-to-day life, they need help. And it's typically the families that are that first line, and we need to take care of our families. So with this grant funding, we were actually able to use some of those funds to get trained from the team at Indiana University. So the person, Dr. Malaz Bustani is his name. He's amazing. He personally trained our team on his model. We sat in a room on, I think, 2 weekends for 8 hours with him on Zoom and our whole team in a room. And he walked us through all of the program protocols, how we do this, how we stand it up. We were able to use that funding to hire a specialized social worker and 2 caregiver coaches. That's what we initially started with. And our caregiver coaches are community health workers, but they kind of bring their own experience working with families with dementia. Some of them have been caregivers themselves, and also a therapist, because we really felt that we needed a professional to address the stress, anxiety, and depression that our caregivers are going through and actually help them access therapy for themselves so they can work through those emotions and really, help get through that caregiving experience kind of a little bit healthier. So we launched this team in 2023 and it's just grown. We've been able to hire several more caregiver coaches. We have expanded our team up to Erie now. We've served over 300 patient caregiver dyads in the time that our program started, and we're really just walking people through the experience. We initially started small. We had to kind of keep it just here in Pittsburgh. We had to think strategically because our team does go out into the home. We had to really focus on, let's focus on the patients and families living at home and trying to make that work that don't have resources. So our team goes out into the home to connect with patients and families, check out the home situation, and really kind of, help give some very tailored advice. And we have been able to grow the program. And just in the last year, Medicare actually launched a similar program called the GUIDE model, which stands for Guiding an Improved Dementia Experience. And health systems had to apply to be sort of part of pilot testing this model. So we applied and we were accepted. So we have launched that. Yeah, we've launched that in conjunction with our Aging Brain Care program. They're very similar models. But with the GUIDE model, people are able to access some respite care also. So they will have funds to help pay for a little bit of some outside caregiver help for their loved one. Right now, this is something that's only available for patients that have straight Medicare, so not Medicare Advantage plans. So it's still a little bit limited, but it's a step in the right direction. Yeah. So it's a step closer to getting some funding, some real funding and structure for these types of programs. And it's just something that we feel is very promising and we're excited to keep moving forward with.
That's awesome.
Amazing. Well, if you ever need any more caregiver coaches, you tell me.
Yeah. Or if you need volunteers or whatever. Is there anything that like our listeners can do to help support? If it's financial, if it's writing to their lawmakers, is there anything that any way that they can help support?
Yeah. We need funding for our programs. Another program that I'm very passionate about that I actually was able to bring to AHN way back in 2016, a few years after I started, is something called the Hospital Elder Life Program, or HELP for short. So this serves our patients who are in the hospital. So our vulnerable patients in the hospital, especially people living with dementia, are very prone to having serious complications in the hospital. I know you guys have been through that with your dad. So that program focuses on preventing delirium, which is when people get more disoriented in the hospital. Sometimes they have behavior changes. Sometimes they're sleepy. Sometimes they can have more distress. It can be a very difficult situation. It can even be fatal for people. So in that program, we actually recruit and train volunteers. A lot of them are students that are interested in going into some kind of medical field or some sort of doing clinical work. We've had nursing students, pre-med, OT, and PT. But we train them and we actually deploy them out into the hospital floors and have them just make visits and really do some specialized interventions. They'll bring therapeutic activities, games, puzzles. They'll sit and socialize with the patient. They'll kind of try to talk to them in a way that helps them sort of stay focused on what's happening around them, kind of reorient them to the situation. We have hearing assistive devices that we use for people that have hearing impairment, magnifiers. We really try to promote mobility with that program so people aren't in bed too long. And that's a program that also was started by an expert geriatrician. But as part of our HELP program, we are involved in a big research study. It's a multi-site trial that's going on through the whole country. We're one of 8 sites. And what we're doing is we are training caregivers and family members on how to engage with their loved one in the hospital to prevent delirium, but to do it in a very interactive way. So as part of the study, we have an iPad that has different activities on it. And they're very simple, straightforward, again, kind of high touch, low tech, but just reminiscing, like pictures of different celebrities from, the 50s and 60s, little like very, easy basic trivia, little prompts, conversation starters. And so as part of our study, we train the families to kind of go through these activities with their loved one because it's supposed to be very interactive, because it's hard to know always how to interact with your loved one, especially if you're there for hours and hours. Yeah, you don't want to be just sort of talking at your loved one. And also you don't necessarily want to, it might not be good for the patient if you're kind of also just sort of sitting, doing your own thing and not interacting at all. So this helps to facilitate that type of two-way interaction. And the families we've trained, they're just loving it. People are really liking it. They want to actually take the iPad home so they can do it. They can keep going at home. So the study's still going to go on for another year or year and a half or so, and we just feel that it's very promising. And my dream would be for something in addition to things like this, but for something like that also to become just part of the standard of care.
Yeah.
So people know what to do and how they can really help.
Yes.
And it's been in existence around the country for about 25 plus years. And we've had great outcomes showing delirium prevention with that program. And it's just good common sense kind of what we call high touch, low tech kind of stuff. So we have that program right now active at West Penn and AGH, but I desperately want to see that program disseminate to our other hospitals. But it takes funding. And even though it takes really just a very small team, we have an amazing program manager and we have a part-time nurse. But it's been, something that we've had to fight for over the years because health systems are struggling, and it's hard for them to understand why we should fund something that isn't necessarily bringing in dollars. And we have really good data that it saves money. It makes hospitalizations go better. People get out of the hospital sooner and they're healthier. But health systems are just really in a tough spot right now. So we've been really looking for more philanthropic funding for both of these programs, more volunteers, of course. I'm always just trying to get more patients into our clinical services just to be able to spread the word about the work we're doing, get better access for patients. So I think spreading the word about the need for things like this, I know there's a need for it. We need to create the demand for it. We need to show our health systems leaders and our community leaders that these things are desperately needed, and it needs to be just part of routine care. It shouldn't be an above and beyond thing. It just needs to be the standard.
If a very rich person is listening and they want to donate money, or if somebody's like, I think I want to volunteer, how can they do that? Who should they reach out to?
Just call us, call AHN Geriatrics. We can get you to the right person for any of these programs. 412 Doctors is the main scheduling line for AHN as a whole. We have our own AHN Geriatrics kind of nurse phone number that we give out to everybody. Our nurses are amazing that they kind of, are able to process all of those calls, but they also understand how important it is for people to just have a phone number that gets to a human. So we are more than happy to share that phone number. We're trying to work on a better website presence through AHN. We have a bit of a website presence. I think we can kind of beef that up a little bit. We're trying to get some marketing out, but definitely would be happy to share our phone number that goes right to our nurse team and get people connected to any resources we can.
All right. So if you're interested, get on our comment section. We will give it to you.
And, it's funny sometimes I'll talk about these different programs to different groups and really just hoping to get the word out and get interest. And it never fails that somebody has said, my parent went through that, especially delirium in the hospital or trying to navigate dementia care in the community, because these are common problems and they're really not talked about enough. And every now and then I'll be talking to a group of health system leaders and somebody will say, always, I've been through that with my mom. So it hits home when it hits home. Yeah. As we both know.
We spent 2 days in the hospital to prevent our dad.
Yes.
Because he's at high risk.
Very high risk.
So we had a sleepover.
And you both saw it. You saw it firsthand too.
We did.
And the reason why he was able to get through that hospital stay is because you were both there.
I absolutely believe that. in real time and real, it's amazing at how quickly it happens.
Yes.
Yeah.
We were only there for 2 days, but like, oh, holy shnikes.
Yeah. Yeah. And the change is quick.
Mhm.
And it's clearly a difference between his normal confusion and delirium.
Oh, yeah.
It's very different.
Mhm.
And we were able to see it.
Mm-hmm.
But I think an outside party might have just passed it off as, well, he has Alzheimer's.
Right.
He's probably just agitated. Like,
Well,
no, this is a scary situation. And I'm a nurse and I'm telling you, this is
yes.
delirium.
And there's definitely a need for more education on that among healthcare professionals. There's a lot of sentiment still that delirium is normal. That's just sort of normal for somebody to get more confused in the hospital. That's part of aging, not a normal part of aging. So we're really working to just educate people about it and for people to give it the serious attention that it deserves, the way we do when somebody has a new oxygen requirement in the hospital, or if somebody's kidney numbers are out of whack. We're very in tune to those issues, but if somebody's brain is failing in the hospital, we need to pay attention to that. We need to identify it early. We need to intervene. We need to prevent it. So trying to create and spread that education is something we're working on, but also educating families, because when families are empowered with that knowledge, it can make a huge difference. And, thankfully you're a healthcare professional and you came in with that knowledge, but I really try to teach our families and to let them know how much of an important role they play in preventing these types of outcomes for their loved ones. But then that's hard because that is a lot of pressure for people. People have to work, and
Right.
It is.
and people are taking care of kids and have a lot of obligations. So it's tough. It's a tough situation. But yes, absolutely, your dad did much better through that hospital stay because you were both there and you knew what to look for.
On our next episode with Dr. Weinberg, don't Google it. Dr. Weinberg is going to teach us the difference between scary words that aren't so scary, like hospice and palliative. So thank you for listening to another episode of Where's the Adult? And that's it for Pitt.